Thank you so much, and thank you so much for having me. So I am taking the other half of this argument, mechanical circulatory devices for acute PE, and I am telling you absolutely not. I have no conflicts of interest, so my job is to convince you that anticoagulation does the job most of the time, that lytics are quick and safe options, that I'm going to help you pick the right vasopressor in patients who are hemodynamically unstable. I'm going to remind you that devices are fancy, but they don't fix the clot. I'm going to tell you Impella and Smella, ECMO is a no-no, and surgery is the way to go. So what clots are we talking about? And as Dr. Relly pointed out, we're really only talking about the high-risk clots or the intermediate high-risk clots. And I would say that I'm going to argue with you that actually the high-risk clots we know what to do with. And really what we're getting down to in this controversy is the intermediate high-risk clots. Where do we go with those? And so if we look at which PEs and how prevalent this is, we find that about somewhere between 10 and 30% of PEs will fit into this intermediate high-risk group, and about another 5 to 10% would fit into the high-risk group. And from there, the all-cause mortality of the intermediate high-risk group is less than 10%, and it can be much higher in the high-risk group depending on if people are actually in cardiac arrest or not. But what we do, and I'm glad that we kind of made the analogy to CABG versus PCI, is this, I would say that the analogy to treatment is more analogous to your analogy of starting heparin in someone who's having a STEMI or giving aspirin. These are what we do to lower mortality. And if you give anticoagulation early in people with acute PE, you notice that there's prolonged survival benefit even at 30 days. And we can see the inpatient survival benefit go about 80% down, and the 30-day mortality benefit continue on about 2/3 reduction. And so really it's time to anticoagulation that is the issue, as kind of Dr. Riley pointed out, time to treatment that is so important. And that can be done with heparin when there's time, but if there's not time, then there's clear evidence to support that thrombolytics can improve this much more quickly. And I guarantee, even though thrombolytics can take some time to deliver, as we talked about, the maximum dose we could give is over 15 minutes. But I do think that getting in the right setting where your ECMO cannulation team might be at home, that might be much faster than you could actually get the ECMO catheters in. So I think that time is of the essence, and that giving thrombolytics and dissolving the clot away is what you should do. And what we find is that RV dilation improves very rapidly, that we get most benefit for patients who have had an acute PE and had symptoms less than 48 hours, but we can have symptoms up to 14 days and see this acute benefit, and that we see very high improvements in RV strain, over 90% success with this. And while we did speak about some contraindications, they're really not as many as we would think. Hemorrhagic stroke, of course, is one, and recent ischemic stroke. But other than major trauma and active bleeding, there's not that many more absolute contraindications to fibrinolytics. If we go by meta-analysis, we can see that there's really very little controversy, I think, surrounding massive PEs doing much better with fibrinolytics. And I think that this is a clear benefit that shows that in people with massive PEs, quick reperfusion with fibrinolytics, much better. The controversy I think that we should be talking about is more whether we should be giving them to these intermediate risk PE patients, and whether they would benefit from the fibrinolytics, the anticoagulation, or the support in anticoagulation. And this goes similarly to the analysis that Dr. Riley was talking about, that even though fibrinolytics do a better job, that there is some increase in bleeding that occurs. However, this seems to be much more powered by the older populations. And so if we have a young patient who's not doing great, but may benefit from fibrinolytics, the number needed to harm is way over 150. And so these people would do much better with fibrinolytics than waiting for your cannulas to come in from home. So how best to support people while we allow the medications to work? And all MAPs are not created equal. This is a canine study that basically shows that while we can augment MAPs with things like phenylephrine, that norepinephrine actually improves cardiac output much better, and that our RV minute myocardial blood volume is over 100% improved with using norepinephrine. So sometimes just using the right medication to stabilize your patient is very important. And if we look at other medications that we can use to support a patient while we wait for our medications to work, dobutamine is a great option. You can see an increase in cardiac index from 1.7 to 2.3 in just 30 minutes prior, 30 minutes after initiation, increased stroke volume, decreased PVR, and increased survivability in these patients as well. If we look at other devices like the Impella device, which is one of the mechanical or circulatory devices being used in pulmonary embolism, it is very difficult to have any sort of support for this. In 2 years, one study found 5 patients that they used this in. And if you look, that they went from a cardiac index of 1.7 to 2.5. If I remind you, that's the same thing that you did with dobutamine, and it didn't require going to the cath lab, placement under fluoro, all of these other things for your patients going on. Also didn't have as many hematoma bleeds, which you see in the insertion of the Impella. Additionally, you can continue CPR throughout an entire thrombectomy if you need to. You don't actually have to wait for cannula. So this is a study that shows inpatient cardiac arrest, and 7 patients underwent active CPR while undergoing percutaneous mechanical thrombectomy. And they showed that basically of these, only 1 patient died and the rest of the patients survived while undergoing active CPR. And so if you do have a mechanical CPR device, this can be an option without inserting cannulas. And I'm going to remind you that there is much more support for using surgical embolectomy than ECMO support. And in fact, you can see in a New York State registry and in other registries that this survivability is well proven in submassive, massive with, and massive without arrests for thrombectomies. And so surgical thrombolectomy is definitely the most proven way to treat a massive pulmonary embolism if TPA is not to be used. And I'm glad we brought up the guidelines, because in the guidelines, we say that there's no clear clinical benefit unless combined with a surgical embolectomy. And that this means that we really you're kind of making a patient undergo 2 therapies. Additionally, if we look and break down the guidelines even more, we see class 1 indications for heparin, class 1 indications for TPA, and class 1 indications for surgical embolectomy. But we have to go all the way down to a 2B recommendation to even consider ECMO. And that would be in conjunction with another procedure, not by itself. And so while there have been case studies that have shown people being put on ECMO and waiting for heparin to work, that is not what's recommended in the guidelines. So I would urge us to continue to go with the guidelines and give TPA when indicated and go to surgical embolectomy if needed.